Could inhibition of C1q effectively halt the progression of GA?
I'm Scott Kriswanis, I'm here with Greg Notstein, and you are listening to New Retina Radio from Retina Today and Bryn Mawr Communications.
Dr. Joel Pearlman sat down to discuss findings from the Phase 2 Archer study, which evaluated ANX007 in patients with GA. He tells us what happened when patients were dosed with ANX007 for 1 year, and what occurred when patients stopped receiving treatment.
And Dr. Dimitra Skondra fills us in on the latest research regarding a potential interaction between Metformin and AMD development in non-diabetic patients. Does the future of care include Metformin as prophylaxis? Stick with us to find out. C1q is all the way at the top of the complement cascade. Blocking C1q for neuroprotection could, in theory, prevent synapse loss and prevent photoreceptor death. But how have patients responded to a dosing of a C1q inhibitor? At ASRS this year, Dr. Joel Pearlman shared data from the Phase 2 Archer trial, which assessed a C1q inhibitor called ANX007 in patients with geographic atrophy. He's here with us in our mobile studio in Stockholm. Dr. Pearlman is in practice at the Retinal Consultants Medical Group in Sacramento, which is part of Retina Consultants of America. Dr. Pearlman, welcome to the show.
Thank you.
Give us a refresher on C1q and where it fits into the complement system.
The complement system is an innate immune system that we use mostly to fend off pathogens, bacteria, viruses, fungi, and it's not specifically dependent on B cells and T cells for its activity. But there are three arms to the humoral complement system, the so-called classical pathway, which is initiated by a protein called complement factor 1, or C1. This is a pathway that's basically driven by antibodies recognizing foreign invaders, and the complement system is activated through C1 to eliminate the pathogens. There are other elements of the humoral complement system, the so-called alternative pathway, where the walls of the pathogens themselves activate the cascade, and there's a mano-selecting binding pathway where sugar moieties on the surfaces of the pathogens activate the complement system. So in the Archer trial, we looked specifically at C1q inhibition, which only affects the classical pathway.
Okay, so we're going to put a pin in that, and then we're also going to talk about some of your presentation, which looked at RPE loss in patients with geographic atrophy. Can you tell me what you found there?
Yeah, so the initial design of the Archer trial was to look to see if the classical complement pathway was involved in retarding the development of geographic atrophy, loss of RPE and photoreceptors. And the study turned out not to meet its primary endpoint. We didn't see any significant change in the rate of growth of geographic atrophy with this inhibition.
Now, what about ANX007? This was the drug that you investigated in Archer. Can you tell me a little bit about that agent?
Of course. So ANX007 is a humanized monoclonal Fab fragment specifically designed to inhibit C1q. So the drug itself is an inhibitor of the classical complement pathway through C1q inhibition.
And it's an intravitreal injection?
It's an intravitreal injection.
All right, so Archer, it's a phase 2 study. It has a sham arm, and then it has 2 treatment arms, correct? There was a monthly and an every other month?
That's correct.
And what were you and your colleagues hoping to uncover? Give me a top-line view of the mission of Archer.
So the initial mission of Archer was to look to see the effect of C1q inhibition through ANX007 on the rate of progression of geographic atrophy. And as I mentioned, it turned out not to meet its primary endpoint. However, we did see some effect on visual protection with C1q inhibition.
Yeah, what did you find there specifically?
So the patients who were in the treatment arms, either monthly or every other month versus sham, showed less loss of 15 or more letters during the 12-month study duration.
Okay. And now I understand you also broke down the patients into 2 subgroups, right? There was a foveal involvement and a non-foveal involvement subgroup. What did you find when you broke them down?
That's correct. The drug seemed to have similar protection against visual loss for both foveal lesions and lesions that started outside the fovea.
You looked at low luminance visual acuity, and I'm curious, 1, why you did that, and 2, what you found there.
So contrast sensitivity is significantly lost in patients who have macular degeneration or macular disease of almost any kind. So the low luminance visual acuity arm of the trial was basically to see if the effects persisted under low luminance conditions. And we found that both BCVA and low luminance visual acuity both showed the same protective effects in the phase 2 trial.
The study stopped at 12 months. Patients stopped receiving the drug, but you continued to track them after they stopped receiving the drug. What happened there?
So interestingly, once patients were off treatment and continued just in follow-up, the effect on visual protection appeared to be lost. So during the 6 months post last treatment, the visual acuity loss rate was similar in all of the study participants.
Okay, so that would suggest that there was some relationship between the drug and
yes, that
disease
suggests
activity.
that there's some effect of the drug that was then lost with cessation of treatment.
What's next for ANX007?
We've learned enough from the phase 2 trial to justify a phase 3 trial, so a larger trial looking to be sure that we can see these visual protective effects on a larger cohort of patients. So Archer 2 is going to launch imminently, and that will be ANX007, the C1q inhibitor, versus sham in patients with geographic atrophy. Somewhat later in the year, there's likely to be the Arrow trial, which is a head-to-head trial of ANX007 versus Syfovre, which is an FDA-approved drug for the retardation of geographic atrophy growth.
Now, assuming that, and this is assuming a lot, but assuming that the outcomes are similar in a pivotal study and that and this drug was approved by the FDA, where do you see ANX007 fitting into a treatment paradigm?
I think one of the tremendous unmet needs in geographic atrophy is vision protection. And if you go back and look at the history of retinal pharmaceuticals, most of the endpoints were visual rather than anatomical. In geographic atrophy, it's a little more complicated because anatomical endpoints are more readily achievable. None of us really thought that we could protect against significant vision loss. But if we can achieve a visual outcome, I think it meets a tremendous need in the dry AMD geographic atrophy population.
Dr. Pearlman, thanks for swinging by the studio and thanks for educating us.
I appreciate the opportunity.
We've discussed the treatment of geographic atrophy on this show plenty of times, but we have not discussed prevention of GA much at all. That changes today when we sit down with Dr. Dimitra Skondra, whose presentation at ASRS 2024 covered metformin and the onset of new AMD. She's here with us in our mobile studio in Stockholm. Dr. Skondra is a professor of ophthalmology at the University of Chicago, where she is also the director of the J. Terry Ernest Ocular Imaging Center. Dr. Skondra, welcome to the show.
Hello, Scott. Thanks for having me. It's always great to be here and discuss about our work and also exciting findings in the retina field.
Great. So let's start with metformin. Give us a download on this drug. It's been around for decades as a treatment for non-ocular conditions, but it's not something that we hear about in ophthalmology every day.
Sure. So metformin is one of these drugs that is been emerging as a novel agent to be used beyond its classical use. So it's the most common prescribed pill for type 2 diabetes. It's been around for 3-4 decades, but there's a lot of new data emerging showing that it has anti-aging properties. So people that take metformin be found to have less morbidity and mortality compared to people like that don't even have diabetes at all. So that has kind of like shown a lot of new directions in kind of potential use of metformin. And the interesting thing about metformin is it's a very attractive agent because it's already been given even with patients without diabetes, like people that have pre-diabetes or people that have polycystic ovaries or metabolic syndrome, and it's very well tolerated. So it doesn't cause hypoglycemia in people that have diabetes. It has pretty safe side effect profile. It's very affordable, and it's also very accessible globally. So even in countries that may not have access to this kind of neurodegeneration, very expensive drugs like South Asia or Africa or South America. So overall, it's a kind of like a drug that has attracted a lot of attention in the aging world, borrowed by literature from the diabetes.
Got it. And now there's been a handful of studies published that look at the relationship between metformin and AMD formation, right?
Yes. So that kind of like triggered these findings, kind of us looking into aging disease of the retina. And we started this work about 7 years ago. Overall, looking to see if there is a signal as metformin and any AMD, a new onset of any AMD. And we published the first study in 2021, JAMA Ophthalmology, showing that people take metformin have decreased risk to develop a new onset of any AMD. And then it was a follow-up study that has a new onset of dry AMD. And that was in patients that had mostly diabetes. But as we know, most of our AMD patients do not have diabetes. And since there is a cohort of patients that take metformin for non-diabetes diagnosis, we look at only non-diabetic patients in a follow-up study that was published in JAMA Ophthalmology last November. And we found that the signal was even stronger, up to 20% less odds ratio to develop new AMD and new dry AMD in patients without diabetics. But it's diabetes. But, the holy grail of kind of like ophthalmology and retina in our field and AMD is geographic atrophy, that, the landscape have changed in the way that we do have some options to treat after GA develop. There's no really zero options to prevent it before it gets there. So given having seen all the signal in patients in our studies with metformin and AMD and dry AMD, we decided to design a study just looking for new onset of diagnosis of geographic atrophy. Since 2017, there is an ICD code dedicated for geographic atrophy that was not available before.
Okay, I see. So you're able to then design a retrospective study looking at, I guess, a claims database, right?
Yes, exactly. So we use the Meditative claims database that has both CPT codes for eye exams and procedures, ICD codes for diagnosis, and not just for the eyes, but other comorbidities. So you can kind of match your subject, but also prescription information. So it's not based on what the patient tells you that may be taking, or when you check them in the chart, but they're actually prescriptions that were in the system by the doctor. So it's a little more reliable than just debating a chart review of what the patient tells you at the beginning of the visit and what the nurse writes down.
Sure. Yeah. So that makes total sense. And then you had to match those patients with some controls, right?
Yes,
How
exactly.
did you end up doing that?
So basically, we pulled up, first of all, patients the first time they get a GA diagnosis from 2017 up to 2021, and we had about 10,600 new ICD-10 diagnoses of GA. And then out of a pool of millions of patients, we match patients that do not have the GA diagnosis, that are match controlled and also morbidity controlled with Charles Comorbidity Index and age and the location and where they are located in the US. And then we collected and look backwards to exposure not only to metformin, but all medications. And then we did a multivariable logistic regression analysis to kind of like adjust for risk factors for AMD, like obesity and smoking, other medications, the presence of diabetic retinopathy if they have diabetes, presence of not of diabetes, and see if people that take metformin have decreased risk of being diagnosed with geographic atrophy, ICD coding of a geographic atrophy, compared to patients that do not take metformin. And we did that both in the fall cohort, including diabetic patients and non-diabetic patients, and then we did also only diabetic patients with a new matching just for the non-diabetic patients to really identify a more clinically relevant scenario and signal.
Got it. So you started with, you said, about, 10,600 patients with new onset GA?
Yeah, in those that have both diabetes and the whole cohort, and then it was 7,600 new GA cases in the non-diabetic cohort alone.
I see. So among the non-diabetic cohort, you then had to filter for metformin exposure. How many patients did you end up with metformin exposure?
I think it was about independent. So those that had GA, there were about 29 patients that had in the GA group that had on metformin, and 63 patients in the control group. So basically doubled the number of patients that were taking metformin in those that did not have GA.
All right, and then the golden question. Did you find any relationship?
So we're very excited to see that in the whole cohort, that include patients, obviously, they're sicker, diabetics, with all the comorbidities that comes along with it. Patients that were taking metformin have 12% decrease odds ratio to be diagnosed with geographic atrophy. But the real exciting part was like in the patients that don't have diabetes, the decrease in the odds ratio was almost 50%, 47%. Less odds to be diagnosed with geographic atrophy, ICD coding, if you take metformin. And I think that that's very exciting because this is what most of our patients reflect to. And an interesting point is that because the numbers were smaller, and you want to see if it's a real effect in the non-diabetics, because it was very impressive, we want to make sure that the robustness was there. So the way to increase the robustness, especially when you look at smaller groups and smaller numbers, is to increase the ratio with control. So, in this initial comparison was 1-to-1, but then we also compared to 1-to-2 and 1-to-3. So basically we put even more controls randomly to see if it was just like an incidental randomness that, the control group that the first time was selected happened to be
Sure. So what did you find there?
that was persisted. So when we matched 1-to-2 or 1-to-3, so for one case with 2 controls or one case with 3 controls, the protective effect persisted to like in the upper 40s for the geographic atrophy metformin. Makes you feel that this is a real signal and not just an outlier.
Yeah, this doesn't seem like noise then. You also looked at the NNT, which is the number to treat. This is a metric that some of our listeners probably know, but it might be new for some of them. Can you walk us through the NNT and then tell us how that's relevant to your research?
So the reason we did that, it was kind of like a different way. What does it mean in a real world? Like if you could treat patients, basically NNT means patients you need to treat to prevent a bad outcome. So in this case, it would be how many patients do we need to treat with intermediate AMD, early intermediate AMD, to prevent one case of geographic atrophy. And for the whole cohort, include diabetic patients, that would be 355 patients to treat to prevent one patient with GA. And for the non-diabetic cohort, it would be 90 patients. That taking a very small conversion rate. So this is if you calculate 2.4% of patients with intermediate AMD will develop GA over 2 years. Obviously, the higher some of the patients are higher risk, or the longer you observe these patients. I mean, some of these patients have intermediate AMD for 10, 15 years until they get geographic atrophy. This percentage goes higher. So the 2.4% go up to like 20, 30%. Of risk of conversion to GA, which means the number to treat will get even less, and maybe even even like 30 patients or 20 patients you treat to prevent a GA.
I see.
Which makes it very attractive because now we're talking about a non-invasive treatment. So the idea is to target people early on. So
and like you said, it's an oral administration. It's inexpensive. It's easy to come by.
It's safe, and also it may help other aspects of the body as well. Like it may help with cardiovascular risk, it may help with dementia, frailty. So it may be not just the eyes. You may be promote a healthy aging overall.
All of this sounds promising, but what do we need to see metformin actually being administered to patients? Is this more retrospective data? Is it an actual clinical trial? What are the next steps here?
Well, this is a start. So this is definitely not enough data to go say, okay, everybody or patients that have intermediate AMD, we should start giving metformin. But this is a very exciting signal, and it's a completely unmet need. As you said, there's nothing really right now in the landscape of GA to prevent it before we get there. All the trials are focusing in slow it down once we get there. And it's a very hard disease to control as we find out. So the next step is obviously confirming that this signal is also there with other databases. So this is a claims database that is privately insured patients. So that have also secondary insurance with Medicare. So it would be interesting to see in primarily Medicare populations. Also, we cannot see really demographics, race in these patients. So we need to make sure in data sets I have more information regarding demographics and regarding representation by insurance coverage, but also other databases that may have more eye-related information regarding imaging, vision acuity, so we can double check that this is truly GA, this is actually makes a difference in the vision outcome. But I think that eventually, even we find more signal in other trials, in other studies, we cannot really implement as a clinical treatment unless we do a prospective clinical trial. Basically, have patients that have intermediate AMD and start them on metformin versus placebo and watch them over 3 to 5 years. I would say more like 5 to really capture the signal and see if people that would get metformin develop less geographic atrophy or later, or less the secondary wet AMD or both. Actually, we have another study that we presented last year that metformin is associated with decreased risk of wet AMD as well. So that's the idea, that we slow down the process before they get to the advanced stages, and once they get to advanced stages, then we have all these other therapeutics that we can apply.
If we're talking about a possibly 5-year study, in patients and we need a huge population, that is going to be an expensive trial. The drug itself is not expensive, but the logistics of it are. Would this be something that you envision being run by, I don't know, the NEI or something that would be privately funded by like Foundation Fighting Blindness? How would the funding even work?
So
for
the
this?
funding is going to be challenging in the way that, most of these trials usually are done by companies, industry, but because the drug is not out of patent, there's generic versions, it would be very hard to get an industry-sponsored trial. So I think as a field, we need to come together and actually I'm talking with Jay Stewart from University of San Francisco, California, to apply for funding sources to do a multi-site prospective trial and look out for funding agencies like the NEI or foundations. But it has to come from funding sources outside of main industry like most trials are. And that makes it a challenging trial because, as we said, it's longer, it's larger. The logistics are more complicated because you need to recruit so many patients. And it's going to be an expensive trial. But I think it's important for the field because it can really change the field if that's the case. It's millions of patients that are going to be targeted. As you said, the AMD numbers go up, and metformin is a drug that can be easily provided. So it could really change the way we approach the disease if the trial happens and it works.
Dr. Dimitra Skondra, thanks for joining us.
Thank you for having me.
That concludes our coverage of the ASRS 2024 meeting from Stockholm. Even though we're done with ASRS, stick around, folks, because we will have coverage at this year's Academy meeting in Chicago later this fall.
And between now and then, we've got plenty of content coming your way. Be sure to subscribe to the podcast to get episodes sent directly to your feed.